So, good evening, everyone. Apologies for the slight delay. Last Monday we had torrential downpour in Mumbai, and because of that, we had a relatively light OPD at my hospital, at our hospital, KEM. But unfortunately, as luck may have it, the the OPD today turned out to be counterproductive. It turned out to be extremely heavy, and I just got back home, so the slight delay. So tonight's topic is going to be fetal growth restriction. Now, this is a topic that was requested multiple times by a lot of people. It's a very interesting topic, and it took me quite some time to understand. In fact, I would go the distance and say that it took me even a part of my senior residency, beyond residency, to understand it in depth. I will not say that I've understood it 100% even today, because I obviously believe that learning isn't something that I should ever be content with. But I know as a fact that it is a very important topic. And of course, that given that this is an important topic, I decided to do it today. So, yeah. So yeah, I'm just checking YouTube. Yeah, we are able to see. Are we able to see? Yes, we are able to see. So let us begin without further ado. Now, what is fetal growth restriction? First of all, basics for all those old timers or for people who have been using older editions of books like Datta, J.B. Sharma, Williams, everything. There was a term called as IUGR, intrauterine growth retardation. 10 साल पहले growth retardation बोलते थे. After that, it turned out to be intrauterine growth restriction, because people started feeling that retardation was associated with the mental retardation of the fetus. And eventually, as we have it now, it turns out that everything has been abolished completely, and we just call it fetal growth restriction. Now, why has the word intrauterine been removed from it? The reason is that they say that, not they say, the fact is that the repercussions, the sequelae, the complications of everything that has happened to the intrauterine, in the intrauterine environment, to the fetus, is carried forward in the postnatal period. So rather than just calling it an intrauterine thing, and also the fact that this fetal growth restriction, or IUGR, or as it was called earlier, is also caused by a bigger picture of maternal body, maternal conditions, which is why just calling it intrauterine wasn't optimal. So we have just decided to focus it on the thing or the person that is getting affected, and hence it is fetal growth restriction. But ये हो गया बहुत ही informal definition. What is the formal definition of this fetal growth restriction? So the formal definition, and this I am quoting several guidelines. Now, first of all, before I begin, what are the guidelines? You would ask me, what are the guidelines that I'm going to be quoting, or what are the various sources that I'm going to be quoting today? So the various sources that I'm going to be quoting today are going to be, first of all, the recent most 2024 Green Top guideline on fetal growth restriction that was released by RCOG. Next, I'm going to be using the practice bulletin on fetal growth restriction of ACOG, that is American College of Obstetricians and Gynecologists. Then I'm going to be using Indian FOXY guidelines. In fact, a lot of the pictures that I'm going to be using today are from our FOXY guidelines, and those FOXY guidelines have been derived from ISUOG, International Society of Ultrasound in Obstetrics and Gynecology. And of course, the Bible, the one book that I definitely will always refer for every single session of mine, that is Williams, the latest edition. And lastly, another interesting book, a very nice book for understanding, but a book that I wouldn't say that you should be using first up. You should be using it once you have understood the topic a little bit. A very good book, though, Areas. So from all these sources, I have charted today's session, and I've made it in the form of a flowchart so that you, whenever you just want to write an answer or go into your exams, you can just watch this 1.5 hours. I don't know how much would be the length video, and be prepared for it. So first of all, what is the definition? So एक definition वो है जो समझाता है what is FGR. The other definition is how is FGR diagnosed. So the first is going to be how it is defined verbally through words. So it is said to be a pathological condition where the fetus hasn't achieved. I'll be continuously looking at my YouTube channel. So basically, on our YouTube Conceptual channel, you would be getting a chance to ask me whatever queries you have. I'll keep on reading them. I'll be answering them as and how I keep getting them. So where the fetus hasn't achieved its optimal or just growth potential. And this is irrespective of its size. What do I mean by this? Now, what does this mean? I will tell you. Before that, let me just add another point. This, in a way, means that the fetus does not have to be small, need not be small, और small को दूसरा term में दूंगा low birth weight, to be called growth restricted or to be diagnosed as FGR. So basically, apna LBW, that is low birth weight definition, is less than 2.5 kgs. Of course, we know that. So is it likely that a baby that is of 2.8 kg can be called as one who has growth restriction? Definitely, it can be called. So can a baby which is 1.8 kgs. But even the other way around, a baby that is, let's say, of 1.8 kg may be normal and not growth restricted. So it goes two ways, both ways. So broadly, what I'm going to say is that fetal growth restriction is not equal to small for gestational age. So now what are these two concepts? You all have always heard of these two concepts. Let us just go into a bit of detail for this one. So small for gestational age is a baby which is for that gestational age smaller than its optimal size. जो अपने growth के charts बनते हैं, curves बनते हैं, उसके हिसाब से कम है. Whereas fetal growth restriction refers to a pathological process because of which the baby is small. So what are the various reasons why there should be SGA? But before going there, I mentioned that this is a verbal definition. What is the official definition? Now, official definition का अगर मैं तुम लोग को फोटो या फिर ये दिखाऊंगा, अरे गया किधर? Yes. So if I'm going to be showing you all this, you would see that यहाँ पे, I'll just increase the size here. You would see several definitions that have been given for SGA and FGR. So the latest one, which happens to be my ISUOG and FIGO. Now, FIGO is a body of just OBGYNs, but ISUG is a body of OBGYNs who do ultrasound. So ultrasound wala wo criteria rahega. So the definition of SGA, as has been quoted as recent as 2020 by both of them, is, let me just talk about FIGO right now. Effective fetal weight or birth weight below 10 centile for gestational age. So SGA is basically when the fetal weight is less than 10 centile. Now what is the centile? Centile मतलब क्या होता है? अगर मैं population को जो भी अपना population 1 crore, 2 crores, 10 crores, 1 billion, वो हर एक बच्चे को अगर मैं सेंटाइल्स में डालूं, मतलब उसको मैं 100% में डिवाइड करूं, सो अकॉर्डिंग टू दैट बर्थ वेट्स, सो इन द लोअर 10% जो होते हैं बच्चे, इन द lower most 10% babies are going to be called as the ones who are below 10 centile. So small for gestational age is less than 10 centile. Anything less than 10 centile. Whereas the definition of FGR is that the small fetus, मतलब less than 10 centile तो है ही, but it has also failed to achieve its growth potential because of some pathological process. Now, which pathological process? Everything I'm going to be talking about now, but this is what is the definition and the difference between FGR and small for gestational age. Now, there is something called as high risk FGR, which has not been specified anymore. So this is an obsolete term now. So all we have is SGA and FGR. So now when I come back to my other, yeah. So now what are the various reasons that I can have a baby who is at a lesser weight than its own gestational age? So let us assume I have a 36 weeker fetus and uska वजन जितना होना चाहिए, it is less than that. What can be the various causes? The most important and one of the most lost out on cause happens to be wrong dates. ये wrong dates क्या होता है? Assume कर लो कि एक पेशेंट ने मुझे बताया कि उसका LMP है 11/11/24. इस हिसाब से उसका ईडीडी आएगा, दिस इज द एलएमपी एंड द ईडीडी. इस हिसाब से उसका एलएमपी आएगा, सॉरी ईडीडी आएगा 18/8/25. But this female happened to be an obese female because of a sedentary lifestyle. And because of that, she used to get periods once in 3 months, 4 months, and she used to ovulate very irregularly. But fortunately or unfortunately, she did ovulate, but that ovulation occurred in the month of December. But she thought that her LMP was in the month of November, and that is her last menstrual period. But actually, she had not ovulated in the month of November. Instead, she had ovulated in the month of December. She had not bled in December because of her PCOS. So actually, if she would have not been a patient of PCOS, her actual LMP probably would have been 11 December 24. So now if I'm going to talk of this patient, इसका आज के तारीख में, आज का तारीख है 25/8, इसका जेस्टेशनल एज होता 41 वीक्स, बट इसके हिसाब से इसका जेस्टेशनल एज होता 37 वीक्स. तो ये जो 4 वीक्स का डिफरेंस आया, इसको कहते हैं रॉन्ग डेट्स. Wrong dates can also be because a female forgot about an episode of menstruation, maybe because it was too scanty, or maybe she didn't menstruate at all, so she randomly just told some date, and out of like fear of being scolded, a lot of people in civil hospitals actually do scold their patients for not being able to remember their for not being able to remember their, what do I say, their menstrual period, which is why she just faked some date, and hence it turned out that it was just a case of wrong dates. Because यू आर एक्सपेक्टिंग कि बेबी का वजन होना चाहिए 41 वीक्स जितना, लेट्स से 3.5 kg, बट उसका वजन है सिर्फ 2.8 kg 37 वीक्स जितना, जस्ट एन एग्जांपल. एंड हेंस यू आर थिंकिंग कि 41 वीक्स पे 2.8 है तो आईयूजीआर होगा या स्मॉल फॉर जेस्टेशनल एज होगा. नहीं, द डेट्स वर रॉन्ग. हाउ डू आई मैनेज दैट? हाउ डू आई करेक्ट दैट? आई विल कम टू दैट, बट बिफोर दैट लेट मी जस्ट टॉक अबाउट what are the other types of SGA. So the other types of SGA include, what if the baby in itself is a constitutionally small baby? What is constitutionally small? Now, Indian women and Indian families in general, if you're going to be comparing your Caucasian counterparts कौन होते हैं तुम्हारे यूरोप वाले, अमेरिका वाले, नॉर्थ अमेरिका वाले, all these people are much taller, much bigger. To give you a straight up example, the average birth weight in these Western countries, in these Caucasians, white people as we call them, happens to be around 3.6 to 3.9 kgs, whereas in India, the average birth weight is 2.6 to 2.9 kgs. Does that mean that our babies are unhealthy or are they weak? No, it does not mean that. It is just that अपना genetic potential ऐसा है, उनका genetic potential वैसा है. And just like that, they have different set of disorders. They have a they have a higher chance of getting some skin cancers or childhood cancers, बहुत सारे, or maybe even things like let's just say autoimmune disorders बहुत सारे. वैसे Indians में metabolic syndrome and a lot of other things are much more common. So it is all a part of a genetic makeup. And wazan, your weight is not going to determine whether you are unhealthy or healthy. Hence, constitutionally small Indian women are usually shorter and thinner and more petite in comparison to their Caucasian counterparts. उसमें भी बहुत सारी औरतें अपने इसमें, because of poor nutritional capacity of the family to feed her when she was a child, when she was an adolescent, they remain small, the pelvises remain small, and eventually they often get married to men who are also of थोड़ा सा shorter height, and इसके वजह से their baby is also going to be constitutionally small. These babies, even when they grow up, when they are born and they grow up and they go to school, are going to be small. मतलब बाकी सब बड़े बच्चे रहेंगे, वो ग्रुप में एक छोटा सा बच्चू रहेगा. It does not mean that this person or this kid is unhealthy or is unfit. No, it is just that उसका genetic potential उसने achieve कर लिया है और वो इस हिसाब से हमेशा छोटा रहेगा. So small mother, small baby is going to grow up to be a small adult. This is how it works. So constitutionally small is वो बच्चा है less than 10 centile है, but that baby is still in the normal range. There is no pathological factor that is affecting them. And how do I know about it? And how do I know that this is not fetal growth restriction and this is just constitutionally small? All the other factor, all the other tests that I'm going to be talking about, be it your Dopplers, be it your fetal infections, anomalies, aneuploidies, all of them are negative. And in this baby or in these babies, your mothers are going to be very small. Your previous babies, मतलब उसके जो elder siblings रह गए delivered by the same mother, they are also going to be of a smaller weight. बताएगी कि मेरा पिछला बच्चा भी 1.8 kg का ही हुआ था, अभी भी ये 1.7 1.8 उतना ही था वो. So that is how all the babies to that mother are going to be small. And hence that is how you can determine whether this is constitutional. You have to not look at the just the baby, look at the mother, look at the husband, look at the father, I mean, and look at the previous kids. उसका भाई, बड़ा भाई, बड़ी बहन रहेगी उसके साथ बाहर लेबर वार्ड के रुके. Look at them and you would get an idea that this baby is only constitutionally small and not having some pathological. So do not look at your report and diagnose your condition. Look at the entire scenario, look at the bigger picture. Now, these two were all non-pathological physiological things. Wrong dates, baby is normal. Constitution small, again the baby is normal. Now I talk about what about the pathological features. So pathological को मैं लाल में बनाता हूँ. So pathological में I have two. एक है non placental factors, मतलब उसमें placenta is normal, वो बोलता है मेरा कुछ लेना देना नहीं है. And the last one is placental factors. Now, what is this non-placental and placental? In non-placental, it has a lot to do with the fetus, that the fetus had some problems, like what? Like the baby may have had aneuploidy, very likely. But the one of the biggest reasons of FGR happens to be, you would see aneuploidy मतलब Down syndrome, no, उल्टा Down syndrome वाले babies बहुत healthy होते हैं. Instead, Edward syndrome, trisomy 18, these babies are very small and काफी बार उनमें ज्यादा कुछ मिलता ही नहीं है. When I do a scan, very often the only sign is going to be a clenched fit or rocker, clenched hands or rocker bottom foot. Only this much. Nothing else might be abnormal. And you might end up missing this, or maybe just choroid plexus cyst. That's it. By the way, choroid plexus cyst is not a marker of Down syndrome. Remember that it's a marker of Edward syndrome, trisomy 18. These might be the only signs. Maybe an isolated choroid plexus, very big cyst, and you just take it, okay, nothing, baki sab normal hai, I won't do anything. But then you start seeing that the baby is not growing. And then you do karyotyping and you realize, Arey yaar, ye to trisomy 18 nikla. This was Edward syndrome. I should have aborted it. I should have done MTP for it. So Edward syndrome, one of the biggest causes for aneuploidy leading to small for gestational age. Apart from that, if there are any lethal congenital anomalies, any anomalies जिसके वजह से बेबी का वजन नहीं बढ़ रहा है, the baby is not growing, things like skeletal dysplasia or CDH. Apart from that, non-placental, of course, one of the biggest causes, torch infections. Oh, one more thing. Torch infections में we of course know T is for toxoplasma, R is for rubella, C is for cytomegalovirus, and H is for herpes simplex virus. But do you know, T के बाद जो O आता है, it is not a part of toxoplasma का TO. That O stands for other intrauterine infections, which includes varicella, syphilis, and yeah, these two very important, and parvovirus. Yeah. So these three very important infections are that actual O. So वो O का meaning है other infections, other intrauterine infections. Do not forget that. So torch में TO is not toxoplasma, only T is toxoplasma. These are the reasons, or these are the ways in which non-placental factors, when the placenta is absolutely normal, it is the fetus who is having a problem. And the last one, the most important, and what is going to be a reason or a major cause for a major point of discussion today, placental factors. So placental factors may, it is going to be what we classically know as uteroplacental insufficiency, जिसमें डॉपलर में कुछ ना कुछ तो गोची आने वाला है. Now, I've mentioned all these things. How do I classify them? How do I remember them very easily? I know these causes, but इसमें क्या क्या differences आएंगे? How do I know क्या क्या गलत है, क्या क्या normal है? For that, I have made a very nice thing. I've made 4 questions that you have to ask to every baby with SGA, and you would get the diagnosis of whether it is wrong dates, constitutionally small, non-placental factor, or placental. A set of 4 very important questions. Before I proceed, I'm just looking at my YouTube. Let me know if you all are understanding this session, and if you all want me to answer any doubt, just let me know. We have a live of 102. I'll also have a sip of water. Yeah. Please let me know in the chat if you all have any issues. Okay. Proceeding then, please let me know if you all have understood everything until now. I will proceed then. Okay. So, now what are those 4 excellent questions that I have highlighted for you all? The first question is going to be, since when? That is the first question. The second question is going to be, is it symmetrical? The third question, I will tell you what is symmetrical, by the way. The third question is going to be, what do the imaging studies say? And the fourth question is, what do the blood investigations say? Now, since when, symmetrical, ये सब क्या है? तो सबसे पहले मैं symmetrical क्या होता है वो बताऊंगा. So before I go to symmetrical, I just want to tell you a basic concept. Now, your pregnancy goes from 0 weeks to 40 weeks of gestation. So when it goes from 0 weeks to 40 weeks of gestation, Gaurav ji, just a request, please keep the live chat on बाद में के लिए भी, so that I would be able to read the comments बाद में as well. Okay. So 0 to 40 weeks के बीच में अपना pregnancy रहता है, उसमें जो अपना ये point रहता है 15 weeks तक, is my period of organogenesis. I know that. Mostly 8 to 15 के बीच में. This phase, पूरा 0 to 15, or you can even say till 20 weeks, is more for hyperplasia. हाइपरप्लेजिया के लिए है ये फेज जो मुझे दिया गया है. हाइपरप्लेजिया मतलब द नंबर ऑफ सेल्स आर इंक्रीजिंग. रिमेंबर दैट द नंबर ऑफ cells are increasing. Whereas the second half, that is from 50 or 20 to 40, the second half of pregnancy is more about hypertrophy. मतलब ये cells नहीं बढ़ेंगे, cells बन गए, now they will only increase in size. So the multiplication is done in the first half and size is increasing in the second trimester. So second and third trimester. So depending on when is that insult or when is that pathological factor coming up will determine whether you have symmetrical or asymmetrical IUGR. So if your hyperplasia का phase is affected, तेरे पूरे बॉडी के जो सेल्स है वो एक समान कम बनेंगे. So the baby is going to be symmetrically small. So if there is any infection or any aneuploidy or any abnormality that you have since day one of your pregnancy, it is going to lead to symmetrical IUGR because your entire body, when it was in the multiplication phase, is getting affected now. So the number of cells will reduce. What about hypertrophy? So if there is any factor that affects in the second and third trimester or the second half of pregnancy, then the सेल का साइज जो कम ज्यादा होता है वो अफेक्ट होना शुरू होगा. प्रेफरेंशियल ट्रीटमेंट होगा. In that case, the abdominal circumference, your abdominal organs are going to be sacrificed first. Why? Because the body says, I have to save the brain. I have to ensure that the head circumference, the brain stays normal. Whereas all those relatively useless organs like my abdominal fat, my liver can be sacrificed. So it will sacrifice on the abdominal circumference, whereas the head will be maintained because oxygenation and blood supply to the head is the topmost priority, and hence the head stays big and the abdomen goes small. This is called as asymmetrical IUGR. Asymmetrical IUGR happens mostly in the second and third, late second and third trimester, whereas hyperplasia वाला symmetrical IUGR happens पहले वाले दिनों से. So अगर रॉन्ग डेट्स है, सो बेसिकली वो तो फिजियोलॉजिकल है, तो ऑब्वियस सी बात है, इट इज वेरी ऑब्वियस दैट बी it won't be asymmetrical. So before that, since when? The wrong dates have been wrong since day one of pregnancy. So since when was this baby small? It was small right since the first trimester. Similarly, this constitutionally small was genetically small. मम्मी डैडी पहले दिन से ही छोटे थे, which is why right from their first trimester the baby is going to be small. So wrong dates and constitutionally small, very similar. Next, non-placental causes में you are going to have a problem over here. The problem is going to be that whenever it occurs, if it is aneuploidy, then it is going to be from first trimester. Similarly, if it's a congenital anomaly, it can be from the second trimester, but it can also start manifesting in the second and third trimester. Why? Things like coarctation of aorta, skeletal dysplasia, congenital diaphragmatic hernia, all these things manifest in the second and third trimester, which is why often they are missed in the anomaly scan as well, which is why this can manifest at any first, second or third trimester. Similar to torch infections. टॉर्च इन्फेक्शन जरूरी नहीं कि फर्स्ट ट्राइमेस्टर में होगा. अगर फर्स्ट ट्राइमेस्टर में हो गया तो सिमेट्रिकल होगा, अगर सेकेंड या थर्ड में हुआ तो एसिमेट्रिकल होगा. तो दीज बोथ कैन हैव एनी ट्राइमेस्टर इन विच इट अकर्स. प्लासेंटा इज फॉर्म्ड एट अराउंड 12 वीक्स. कंप्लीटली 12-14 वीक्स तक हो जाता है. तब तक फर्स्ट ट्राइमेस्टर तो हो चुका है. सो ऑल द प्लासेंटल कॉजेस विल ऑब्वियसली बी ओनली देयर इन द सेकेंड एंड थर्ड trimester, second and third trimester. So this is when your SGA is going to start originating from. So whenever you're doing an ultrasound, if it is wrong dates in the first trimester, you will have a smaller crown rump length, smaller fetal height, smaller head circumference. Similarly, constitutionally small baby पहले से ही छोटा रहेगा. But ये non-placental causes तभी से होगा जब भी that insult has occurred. Aneuploidy is since day one. Torch infections can occur at any gestation. So उसके बाद उसमें वो दिखना शुरू होगा SGA on ultrasound. Next, symmetrical or asymmetrical. Wrong dates, the baby is absolutely normal and physiological, similar to constitutionally small. There is no need to sacrifice your abdomen. There is no need to sacrifice your liver. There is no need to spare your head, which is why it is going to be symmetrically small. The baby is going to be small, which is why it is going to be symmetrical here and symmetrical here as well. Whereas when it comes to all the non-placental causes, so non-placental causes may it can be again both depending on whether it was in the first trimester or in the second or third trimester torch infection jaise, which is why it can be both asymmetrical as well as symmetrical. Whereas placental, uteroplacental insufficiency is classically something that occurs very late. Late matlab blood supply placenta se आना कम होता है in the second and third trimester, which is why, especially in the third trimester, which is why that is the peak phase when your abdominal circumference is going to be compromised to save the head, what we also call as the brain sparing effect, which is why these babies are going to be asymmetrical. नेक्स्ट इमेजिंग स्टडीज पे रॉन्ग डेट्स वाला बेबी नॉर्मल दिखने वाला है. इमेजिंग स्टडीज मतलब क्या? NT-NB स्कैन, एनोमली स्कैन, ग्रोथ स्कैन्स, डॉपलर्स, नॉर्मल दिखने वाला है. सिमिलरली कॉन्स्टिट्यूशनल स्मॉल बेबी नॉर्मल दिखने वाला है. नॉर्मल मतलब सिर्फ उसका वजन कम रहेगा, बट बाकी सब जो स्पेसिफिक मार्कर्स है, लेट इट बी ऑन NT-NB स्कैन और एनोमली स्कैन, वो सब नॉर्मल रहने वाले हैं. In non-placental causes, in aneuploidy, it is going to be abnormal, absolutely. In congenital anomaly, your anomaly scan is going to be abnormal. Your torch infections, yes, you're going to get things like intracranial calcification, congenital cataracts. Apart from that, cardiac defects, liver में calcifications दिखेंगे. All these things are going to be seen. Meconium is going to be seen, or what we also call as hyperechogenic bowel is going to be seen. Echogenic bowel is going to be seen. So all these things are definitely going to be seen. So imaging is going to be positive. You are going to get some positive finding. Similarly, in your placental cause, again, your Dopplers are going to be abnormal. Your growth velocity, your interval growth is going to be abnormal, and hence you are going to get positive findings in it as well. Positive findings मतलब abnormal. इसको मैं abnormal लिखना ज़्यादा prefer करूँगा. I'll just write it as abnormal rather than plus. Okay. Lastly, blood investigations. Wrong dates में blood investigations मतलब मैं exactly कौन से investigation का बात कर रहा हूँ? Things like dual marker, NIPT, quadruple marker, triple marker, obsolete. Never do it. It is criminal to do it now. Or maybe I can think of something like karyotyping, genetic studies basically, or whole genome sequencing, CMA, all these tests. Of course, everything of this is going to be normal in wrong dates and in constitutionally small baby, but in placental causes, aneuploidy, congenital anomaly, torch infections, all of these are going to be abnormal. In aneuploidy, your dual marker, your NIPT, quadruple marker, karyotype, everything is going to be abnormal. In congenital anomaly, your whole genome sequencing is going to be abnormal. And in torch, your another blood test called as torch PCR is going to be abnormal. So your blood investigations are going to be abnormal. Whereas in placental, it's a very special case. ये सब में से बहुत सारी चीजें नॉर्मल रहेंगी, लेकिन ड्यूअल मार्कर, आई ऑलवेज सेड दिस, ड्यूअल मार्कर का नाम ड्यूअल इसलिए नहीं है बिकॉज देर आर टू मार्कर्स दैट यू लुक इन इट. ऑफ कोर्स दैट इज द वन ऑफ द बिगर रीजंस की बीटा HCG एंड पैपे आर द टू analytes that you are seeing, but also because it serves two purposes. The first purpose is to diagnose or to predict aneuploidy, and the second is to predict preeclampsia or fetal growth restriction. Your PAP-A is going to be low, your beta HCG is going to be low. So all these markers are going to be predictive of preeclampsia and fetal growth restriction. Hence, dual marker has two purposes as well as two enzymes or two analytes that we test for. Similarly, your blood investigations like placental growth factor is going to be low. Your other several other markers, SFLT2 is going to be increased. There are all these markers that are going to be deranged that you will be needing to look out for, and hence your blood investigations are going to be abnormal. And these are the four questions and four ways in which you can know whether, in which you can know whether it is abnormal or not. Okay. So now, so does anyone have any doubt with these four questions, and has this four question theory made it easier for you to understand what I have been intending to say until now? Any doubts until now, please let me know in the live chat. I'll be waiting for y'all in live chat. Do let me know if y'all have any doubts. Now, the next thing that I'm going to be talking about is going to be the easier part of this session has been about wrong dates, kuch bhi nahi hai, constitution small, nothing to speak about, non-placental, very straightforward diagnosis. The more important problem is with placental and how does it happen. So let us talk about the placental cause of IUGR, or what is also called as very classical FGR. So placental is going to be a major cause of our or major point of our discussion. Now, placental cause may remember that your placenta can get affected early or it can get affected late. So when it is getting affected early, I'm going to call it early FGR. And by early, how early is it supposed to be? At less than 32 weeks. Whereas late FGR is to be diagnosed after 32 weeks. So basically, if the placenta is getting some problems, or there is some problem in the other name for it is uteroplacental insufficiency, if it is setting in before 32 weeks, it is called as early FGR. If it is setting in after 32 weeks, it is called as late FGR. Now, in this early FGR, obviously, there was some problem in the placenta in itself. So, there was some placental dysfunction. प्लासेंटा के अंदर जो भी मेरे वेसल्स है, कोरॉइड वेसल्स है, विलस स्ट्रक्चर है, उसमें कुछ तो प्रॉब्लम था बिटवीन द परफ्यूजन. Whereas in this, there is just supply demand discordance. So basically, the placenta is okay, it is normal, possibly normal, but the baby is growing to such an extent that the placenta that this baby has is not able to provide for its demand. So the supply is increasing, I mean, the demand is increasing, but the supply is not yet adequate. It does not necessarily mean that your placenta is having some pathology in it. How do we diagnose and how do we differentiate between both of them, and how do we know how severe it is? So for that, there were several people who came together to decide upon how should we be going ahead with it. And is there someone who has placed in a question? Which question है क्या? किसने गौरव ने? Sir, you are not after live. Okay, okay, yeah. So of course, there were multiple people who convened and they decided to just discuss as to how do we know whether it is early and late, and how do we know how bad it is. For that, they came together and they called it Delphi consensus. What is this Delphi consensus? Now Delphi consensus was a place जिसमें वो लोग ने डिसाइड किया कि हमें कैसा इसको अर्ली और लेट को डिफाइन करना है. Now how was this done? Now over here you can see that this box that you can see is the Delphi consensus, and this Delphi consensus is what is recommended by all the recent most guidelines. Now this centile. Similarly, the abdominal circumference or the effective fetal weight is less than third centile. But in early FGR, you have another point. That another point is your umbilical artery may have absent end diastolic flow as well. So either this or this, if it is present, then you can call it early FGR or late FGR. But if not for this, what if the abdominal circumference or the effective fetal weight is more than 3 centile? Then they said another we have still another way. That another way ये लोग ने और के जरिए दिया है, or they have said your fetal weight can be less than 10 centile, but with either uterine artery PI more than 95th centile or umbilical artery PI more than 95th centile. So this with either this or this, not both of them. Similarly, in late FGR, they said that at least two of this following. So either this with this, or this with this, or this with this. उसमें से कोई भी दो का कॉम्बिनेशन अगर रहेगा, जैसे इफेक्ट जैसे अर्ली एफजीआर में दिस लेस देन 10 सेंटाइल वाला पॉइंट वाज कंपलसरी, यहाँ पे दैट इज आल्सो नॉट कंपलसरी. दीज टू थिंग्स आर वेरी इंपॉर्टेंट. उसमें से आई विल टेल यू व्हाट डज दिस टू क्वार्टाइल्स एंड लेस देन 5 सेंटाइल ऑल ऑफ इट मींस. आई विल बी टॉकिंग अबाउट इट राइट नाउ. सो ये सब जो डॉपलर के वेसल्स है, आई विल बी कमिंग टू देम, डोंट वरी, आई विल बी कमिंग टू देम एट अ लेटर पॉइंट इन टुडेस डिस्कशन. आई एम गोइंग टू बी टॉकिंग अबाउट ईच एंड एवरी इंडिविजुअल वेसल. बट बिफोर कमिंग देयर, आई हैव स्टडीड अबाउट ये सब होता है. These are all the definitions, these are all the various types of FGR. Now I need to determine what caused them, which patients are predisposed to developing them, or in other words, what are the risk factors to developing these problems. So now the discussion is going to be to determine what are the risk factors. So the risk factors can be from two ends. It can be either from the mother, that is maternal, which she had in herself always, or it can be because something that pregnancy brought along with itself. So the risk factors can either be with the mother always, or it was just the pregnancy that introduced in her. Maternal maybe, were there few things that were innate to her that she cannot modify at all, like demographic factors, or things that could be modified in her, which are medical comorbidities. Similarly, pregnancy matlab, was it the previous pregnancy that is still having a bearing on today's pregnancy, on current pregnancy? Was it something that happened in the last pregnancy, like a stillbirth, or like severe preeclampsia, or like a placental disease in last pregnancy, which has increased the risk of the same thing happening in this pregnancy? So is it something that had already happened? Was it something that the previous pregnancy already had and it gave me a clue that it may repeat again? Or is it something that is fresh in this pregnancy? And probably this is a primigravida, or that female is a multigravida, but she did not have those factors in a previous pregnancy. So these are the two major classifications of how do you determine the risk factors. So how do I determine them? Now for this, I've taken a beautiful picture from a beautiful book called as Areas. Now Areas में ये लोग ने बहुत ही मस्त दिया है ये पिक्चर, you can see. यहाँ पे वो लोग ने सबसे पहले मैं मैटरनल चीजों की बात करूंगा. So मैटरनल रिस्क फैक्टर्स में सबसे पहला बात आता है एज. Now age more than 35, the odds increase by 1.5, and as it grows more than 40, it increases more by 3.2. You would ask me, why should small for gestational age or fetal growth restriction occur with increasing age? Now remember, as your age increases, the quality of your egg and your quantity both reduce. So when your quality of egg reduces, the non-disjunction events, basically aneuploidy का risk बढ़ता है. Now aneuploidy, as we have already discussed, is a cause of non-placental cause of SGA. So that is one reason. Secondly, as your age increases, the risks of you having metabolic syndrome like chronic hypertension, diabetes mellitus भी बढ़ता है. Now these are all those things जिससे होता है endothelial dysfunction. What is endothelial dysfunction? Basically, when you have hypertension because of high flowing blood, high velocity blood flowing in your vessels, it shears off the endometrium. It literally peels off the endometrium from various locations. Now, when this happens, this can also happen in your uterine arteries and your placental vasculature. So when this happens, because your endometrium is getting damaged, your obvious response to it is going to be to form platelet plugs followed by clotting over there. Whenever there are platelet plugs and clotting that occur in any vessel, the blood flow is impeded. Now, whenever blood flow is impeded to anything, there is going to be hypoxia. So this hypoxia, when it happens in the placenta, in the uterine vasculature, that leads to hypoxia in the fetus and it hampers their growth. That is why with increasing age, because of all these other comorbidities, the risks of small for gestational age or fetal growth restriction increases significantly. Next is parity. Why parity? Parity mein they have mentioned about nulliparity. Nulliparity means first pregnancy. Why first pregnancy? Because in first pregnancy, the female's body is seeing the paternal antigen for the first time. That paternal antigen, which is literally a foreign antigen for her, she's seeing it for the first time. Now, when the body is seeing something for the first time, the body is going to mount a foreign body response against it. It is going to start acting against it. It is going to try to रिजेक्ट इट. और ये रिजेक्शन के चांसेस कैसे, इवेंचुअली वो इम्यून टॉलरेंस बिल्ड हो जाता है, बट ये जो प्रोसेस होता है, ये थोड़ा बहुत जो क्लैश होता है बिटवीन द पैटर्नल एंटीजन एंड द मैटरनल इम्यूनिटी, दैट लीड्स टू a little bit of placental dysfunction, and hence that also increases the risk of nulliparity. Nulliparity increases the risk of FGR. Similarly, when it's been more than 10 years between two pregnancies, the body has kind of forgotten about the paternal antigen. The memory cells are also gone from the mother's body. And hence, when the mother is exposed to the same paternal antigen after 10 years, that is again going to increase the risk of small for gestational age or FGR. So, either nulliparity or inter-pregnancy interval more than 10 years. Or one more thing is, if there is a change of partner, if there is a new father, maybe there's a remarriage or something else, the new father comes in, brings in a new paternal antigen, that again is going to be a risk factor, because now there's a new antigen, new response is going to be mounted against it. This is about parity. Next comes body mass index. Obviously, body mass index is directly going to correlate with your metabolic syndrome. Metabolic syndrome is hyperlipidemia, hypertension, chronic diabetes mellitus, all these things. So as your, you can see, as your BMI increases, so is your risk increasing with BMI. Very obvious, nothing more to be said. Very simply understood. The same reason as I mentioned about hypertension. नेक्स्ट मैटरनल सब्सटेंस एक्सपोजर. सिगरेट्स. सिगरेट्स में से निकलता है निकोटीन, टार, ऑल दीज थिंग्स, carbon monoxide. What does that lead to? It leads to, in your body, remember, carbon monoxide, tar, everything leads to hypoxia. Hypoxia, especially in the lungs, will lead to COPD. Now all these things are going to cause hypoxemia in your body, and hypoxemia का एक response होने वाला है to increase the RBC का numbers, which is called as polycythemia. Polycythemia will lead to hyperviscosity, and hyperviscosity will make the blood very thick. Thick blood finds it very difficult to move through the placenta, which is why it makes it very difficult for the fetus to get oxygenated. Secondly, nicotine is something that can cause smooth muscle contraction. It can act on your neuromuscular junction and it can lead to contraction. So it contracts your smooth muscles, and your smooth muscles are going to be contracting, leading to poor supply of your uterine vasculature. So cigarettes and also cocaine, again, cocaine is a psychoactive substance which is going to lead to smooth muscle contraction. Next, IVF pregnancy. Beautiful point. I love this point. Why have we spoken about IVF pregnancy? Of course, IVF mein one point is that you are introducing probably some other donor ovum or donor sperm you may introducing, or higher chance if you're introducing donor egg as well as donor sperm. इसमें क्या होता है? The mother's body is now seeing a new ovum which she has never seen before, and she's also seeing a new sperm. So दोनों नए antigens अगर दोनों के against foreign body reaction होगा, the placenta is going to be even worse. One of the major reasons why in donor sperm and donor egg you get all these placental dysfunction like fetal growth restriction, preeclampsia, severe preeclampsia वाले chances. But there is one more reason. Now, in IVF pregnancy, a lot of times it is not the same cycle in which you stimulate, you create your corpus luteum, you give a trigger, you rupture it, you collect your oocyte, and then you again insert. काफी बार क्या होता है, हम लोग oocyte को preserve करते हैं या फिर embryo को preserve करते हैं और subsequent pregnancy में भी implant it. Now, in subsequent cycle, when we not pregnancy subsequent cycle, now whenever we are implanting or whenever we are doing embryo transfer or oocyte transfer in a subsequent cycle, we are doing it hormonally. We do not let naturally the corpus luteum to develop. We are doing everything artificially, which is why corpus luteum doesn't develop. Now, corpus luteum secretes something called as relaxin. And this relaxin is very important for your remodeling of the vasculature between the uterus and placenta, and also in your entire body. It relaxes all your smooth muscles of your blood vessels, of your arteries. And that is why whenever your corpus luteum is absent, which happens in frozen embryos wherein all because of hormonal stimulation you are not getting a corpus luteum, that increases the chances of you getting hypertension, preeclampsia, and placental dysfunction because your relaxin hormone is absent. Now this is something that you may not find in most books. It is something that I have read in several studies, so note this point, a very important point. Lastly, exercise. Exercise is going to release a lot of catecholamines in your body. Catecholamines, sympathetic drive is going to increase. Sympathetic drive मतलब vasoconstriction तो होने ही वाला है. Lastly, diet. If you're not consuming enough of roughage, if you're consuming diet which has a lot of trans fats, it is of course going to lead to increased cholesterol, hyperlipidemia, and lastly, your the metabolic syndrome. Did everyone understand the maternal risk factors, maternal demographic risk factors that she cannot change? Or does anyone have any doubt with this? I hope everyone has understood this. I'll be just checking live. If anyone has any doubts, do let me know about it. Okay. So next are those risk factors about medical history. What about medical history that do I need to know about? Now, when I talk about medical history, remember that, yeah, small for gestational age and maternal small for gestational age. Basically, if the mother herself was someone who was small, it is going to increase. That's fine. Now, what else? Hypertension, chronic hypertension, I've already mentioned, it shears off your vessels, clots banenge, thrombin banega, udhar platelet plugs banenge, it is going to impair your vasculature. Again, diabetes mein you will have diabetic vasculopathy. Diabetic vasculopathy, same thing as hypertensive vasculopathy. Basically, your vessels are not going to be formed well. They're going to be damaged. Damaged vessels is going to lead to poor perfusion of your placenta and your fetus. Renal disease. Renal disease may your entire body is in a state of chronic inflammation, and that chronic inflammation is going to lead to endothelial dysfunction throughout your body. All those toxins and everything in your body, inflammatory markers, cytokines in your body are going to increase in your body, and that increase is going to reflect in form of endothelial dysfunction. Similarly, Apla syndrome, wherein your Anti-phospholipid antibodies, basically your phospholipids, which are a part of every single cell membrane in your body, they are going to be affected by these antibodies. It includes your syncytial trophoblast. सिंसिशो ट्रोफोब्लास्ट जो होते हैं उसका भी वो बॉडी को डिस्ट्रॉय करेगा, सेल मेम्ब्रेन को डिस्ट्रॉय करेगा, एंड दैट विल लीड टू पुअर रीमॉडलिंग, एंड दैट पुअर रीमॉडलिंग इज गोइंग टू रिफ्लेक्ट इन द फॉर्म ऑफ poor placental formation, poor placental vascularization, and eventually small for gestational age. Similarly, father, if the father himself was a small for gestational age, that is going to be a risk factor. You can see that father being smaller is a bigger risk factor than mother being smaller. And hence, if the father himself is a small petite person, the chance of the baby having SGA is going to be very high. So these were all the medical risk factors and your maternal risk factors that were very important. Now that I've spoken so much about all these placental dysfunction, endothelial dysfunction, I would now want to just talk about kya hai placental dysfunction, what is it, what are those vessels that are affected? So how do these vessels look like? Yeah. So now we know that this is my uterus, these are my uterine arteries. Now, when my placenta, my black se bana raha, is developing on one end, these uterine arteries start realizing that itna patla sa apna diameter hai, I cannot sustain an entire placenta and a fetus to grow inside. I have to start getting dilated, I have to increase in size. But how will, within a short span of time, any vessel increase its diameter? More so because I have three layers of a vessel. What are the three layers? This is my vessel. This is my tunica adventitia that is outside. Then I have my tunica media, and then I have my tunica intima. A tunica adventitia contains fibrous material. Fibrous material is not going to let your vessel get any bigger or increase its diameter. So the body has to think wisely. Of course, if I injure this tunica adventitia, my vessel will literally rupture and there won't be any blood supply. In fact, the patient will die. So I can do nothing to the tunica adventitia. All I can do is to these two layers, which tunica media and tunica intima. So the body says, let me do something and eliminate these two levels, because earlier what was only this small, ये जो बीच का तुम लोगों को दिख रहा है, only this much of a diameter through which the blood was flowing. If I destroy these two layers, I will have this bigger diameter through which blood is flowing completely through this. So basically the body says, rather मैं जो पहले इतने से एरिया से आ रहा था, अभी मैं इतने diameter से आ सकता हूँ, that is increasing my diameter, increasing my flow to the placenta. But how do I do this? The placenta says, I need your blood. You are going to help me. So let me just lend you a helping hand in favor of what you're doing for me. And it says, I will give you something called as extravillous trophoblasts. Extravillous trophoblasts मतलब वो trophoblasts जो विलाय में नहीं रहते, वो बाहर घूमते रहते हैं. It says, I will come to you, and those extravillous trophoblasts are going to destroy these two layers, tunica media and tunica intima. And what will be left is only this tunica adventitia, and the blood is going to flow continuously through these two vessels on both the sides, two uterine arteries. This is called as remodeling of spiral arterioles. These are all the spiral arterioles, which are the smallest, few of the smallest branches of uterine arteries. This reduces the resistance of uterine arteries and a lot of flow can come in. But now, what if these, let me just put in some other color. Let me assume that these were my extravillous trophoblasts that were helping. But what if I have some factor that is destroying them completely? These extravillous trophoblasts are being destroyed. They are not being given their enough space and time to act on. Something that happens in Apla syndrome, or something that can happen if there is some HLA mismatch, or there is some mismatch between the paternal and maternal antigen, wherein जब भी वो मिलते हैं, the trophoblasts have some genetic defect in them that they forget that their function of destroying tunica media and intima is very important. So there are defective extravillous trophoblasts that occur in my body, which is also a reason why a lot of couples get recurrent pregnancy loss. This way, ये जो dilatation है वो हो नहीं पाता है, and instead these extravillous trophoblasts are being broken down. This leads to poor vascular remodeling, and hence the uterine artery resistance in both these vessels, instead of going down, it doesn't go down, it stays high. This is reflected in the form of raised uterine artery resistance index or raised uterine artery pulsatility index. Both are indices of resistance only. This is what is known as raised uterine artery PI or raised uterine artery pulsatility index. Roughly at 12 weeks, it should be less than 2.4, and at 22 weeks, it should be less than 1.2. If it is more than that, then you say basically average of both the uterine artery PI has to be less than 2.4 at 12 weeks and less than 1.2 at 22 weeks. If it is more than that, then we say that the uterine artery PI is high. Because the uterine artery PI is high, the blood flow to the placenta is poor, and because the blood flow to the placenta is poor, the fetus is not going to develop well. Apart from that, because the placenta is not receiving adequate oxygen from the uterine arteries, it is in a state of hypoxia. It will start releasing several hypoxemia wala cytokines, things like soluble FMS like tyrosine kinase, FMS like tyrosine kinase 2, or soluble endoglyne. These two factors are going to destroy your placental growth factor. I will write them in green because they are your friendly factors. They are going to destroy your placental growth factor and VEGF, vascular endothelial growth factor. These two were responsible for growing multiple small vessels between your uterine artery and your placenta. They were useful for increasing the blood flow. ये इनके ऊपर हावी हो जाएंगे, they will destroy them. And they will destroy them, and instead they will increase in your body. These two are also called as hence anti-angiogenic factors because they are against vasculogenesis or angiogenesis, and they also increase the blood pressure. And hence we say that when the uterine artery PI is high, the risk of preeclampsia increases, and so does the risk of fetal growth restriction increases in the second and third trimester. I hope you all understood this very crucial point as to the significance of uterine artery PI screening in the 11 to 14 weeks wala NTNB scan, how useful and important it is. I hope you all understood it. Let me know in the chat if you all have understood it very well. Please let me know so that I can understand कि तुम लोग को समझ रहा है ये topic and तुम लोग को yeah basically समझ रहा है topic. Let me know. So now this was about the uterine artery side of things. Now assume कर लो all of this went perfectly normal and the placenta को perfusion was all well. But now in the placenta, this now assume this was your placenta. यहाँ से आ रहा था uterine artery. This was completely normal and यहाँ पे था your fetus. ये fetus का था umbilical cord. Now inside this you had villus structures. Villus, tertiary villi, you have heard of it. Let's say villus structures. So you have all read about it. Which are the points of oxygenation between the fetal blood and the maternal blood. So baby ka deoxygenated blood goes here and the mother's oxygenated blood comes here. It gets exchanged and then oxygenated blood goes back to the baby and deoxygenated blood goes back to the mother for oxygenation. This is how your normal, very simple uterofetal circulation works. Now, what if due to some reason there were clots or villus or fibrin deposition in this villus? यहाँ पे there was damage. Multiple reasons. There can be villus fibrin deposition और एप्ला syndrome ने एप्ला से यहाँ पे मैंने बोला था पहले एक्स्ट्रा विलस, यहाँ पे एक्स्ट्रा विलस ट्रोफोब्लास्ट सिंसिशो ट्रोफोब्लास्ट थे बट इस पे तो विलस ट्रोफोब्लास्ट थे and that apla syndrome destroyed all of them and this led to a blockage of your villus vasculature and that is why when there was a destruction of your villus vasculature directly the fetus was getting affected. इसके वजह से ये जो लो रेजिस्टेंस वेसल्स हुआ करते थे प्लासेंटा के अंदर का रेजिस्टेंस बढ़ गया. Why? Because its villus vasculature was getting destroyed and destruction say it was getting all crumpled up. Because of this crumpling and destruction, the resistance inside the placenta increased. Now, one point is, this is my umbilical cord. Umbilical cord के अंदर होते हैं मेरे दो umbilical arteries and एक umbilical vein. Umbilical vein takes blood from the placenta to the baby. So basically ये लेके जाएगा towards the fetus whereas ये वाले जो है ऊपर के, they will take the blood back to the placenta. Of course, I know that. The umbilical arteries. Why have I made umbilical artery in blue? Because umbilical artery contains deoxygenated blood, whereas umbilical vein contains यहाँ पे umbilical artery and यहाँ पे umbilical vein. Umbilical artery contains deoxygenated blood, which is why I made it in blue. Now, when the resistance in these villi was increasing, the body found it very difficult to push the blood through these two vessels, through these two umbilical arteries back to the placenta. It found it very difficult to push it back into the placenta and to push it beyond these blocks to get it deoxygenated ka oxygenated. So basically, because of these blocks and destruction of villi, the resistance to the flow of umbilical artery was increasing. It kept on increasing. It initially showed up as umbilical artery resistance या फिर pulsatility index का बढ़ना. So umbilical artery PI का बढ़ना was the first sign of some placental problem that was setting in on the side of villi. This kept on increasing so much that there came a point when the blood could just no longer flow ahead, and that was called as absent end diastolic flow in umbilical artery. You all should have wondered until now that it is the umbilical vein that brings oxygenated blood to the fetus. Then why don't we instead say that absent end diastolic flow in the umbilical vein, because that is the main vessel? Why do we say that the vein that the artery that was carrying deoxygenated blood is having absent end diastolic flow? Deoxygenated blood, it is useless blood. So what is the problem? It is the deoxygenated waste blood that is getting resistance. What is the problem? The problem was that because of this eventually became reversal of end diastolic flow. So instead of this blood flowing from the fetus towards the placenta, which was the ideal scenario, during reversal of end diastolic flow, this blood started flowing ulta back to the fetus through the umbilical veins, through the umbilical arteries. Also, this placenta was anyway sending blood through the umbilical vein to the fetus. So basically, there were two vessels, two umbilical arteries that were bringing the blood to the fetus, and one umbilical vein who was also bringing it to the fetus. What happened was this umbilical artery ka pressure exceeded the umbilical vein ka pressure, and there were back pressure changes. So ये जो fetal heart था, फीटल हार्ट के 4 चेम्बर्स थे, उसमें से जो आयोटा निकल के नीचे जाता था, ये आयोटा के 2 ब्रांचेस निकलते थे कॉल्ड एज कॉमन आइलियक. उसमें से जो इंटरनल आइलियक था उसका ब्रांच था ये अम्बिलिकल आर्टरी. Because of this reversal of flow in this umbilical artery, this blood started flowing backwards through the aorta. It flew backwards to the aorta into the left atrium. Then through the foramen ovale, it flew back to the right atrium, and through the right atrium, it went back into the IVC. IVC was connected to a vessel called as ductus venosus. This ductus venosus was a branch of umbilical vein. And now because of these back pressure changes, we could see something called as A wave reversal in ductus venosus, which is said to be the final stage of uteroplacental insufficiency, or just reversal of wave in ductus venosus. The final stage. The baby is going to die any moment. Even if you deliver the baby already has cardiac damage. Back pressure changes have started in. Heart failure mein baby ja chuka hai. The baby will still not survive even if you deliver it alive. That is how your reversal of DV occurs. Did everyone understand this very crucial concept? Does anyone have any doubt with this concept? Very important. Kindly let me know in the chat if anyone has any doubt with this very important concept. If not, I will proceed to the next part, that is my previous pregnancy related risk factors. Any problem, any understanding my issue, let me know in the chat right now. Did this discussion convince you to understand what is this DV reversal all about? So this was all about all the important vessels, uterine artery PI, what is umbilical artery PI, what is ductus venosus. Did you understand this very significant concept? Let me know in the chat. I'll be glad if you all have understood this very important concept. Now, coming to previous pregnancy related risk factors for SGA. What is previous pregnancy related risk factors? The previous pregnancy related risk factors include if there was history of previous SGA, very important. If the previous baby had small for gestational age, then even in the current pregnancy, you are going to get small for gestational age. Next, if there was a history of stillbirth in previous pregnancy and an unexplained stillbirth, unexplained matlab I'd have no idea why did that stillbirth occur. So very important key, I don't know the cause and probably there must have been uteroplacental insufficiency or the placenta may have had some problem, which is why there was stillbirth. Apart from that, if there is history of previous preeclampsia, previous pregnancy there was preeclampsia, if there was previous pregnancy में preeclampsia, the placenta के formation में there was some problem. If there was problem in previous pregnancy ka placenta formation, in this pregnancy, the placenta which is formed from maternal and paternal antigen, it is going to face the same problems and hence it is going to have the same issue as in previous pregnancy. So very important for all these points to be noted that previous history of anything from these is going to lead to small for gestational age in current pregnancy. Apart from that, dual marker. Yes, I am seeing all these chats. I've seen all the questions. I'll be answering all of them. All of the questions, I'll be answering them at the end of it. Now, coming to the risk factors from current pregnancy. So in first trimester, if there is threatened miscarriage, which is threatened abortion, basically there was bleeding in the first trimester, we call it as threatened miscarriage. Then remember that whenever your uterus, this is your uterus and your placenta has implanted over here, if there is marginal separation of this placenta, just छोटा सा separation, ऐसे छोटा सा यहाँ पे separate हो गया placenta और यहाँ से bleeding start हो गया, remember that this placenta is never going to get attached again and this part completely is gone. The vasculature that was coming from this part is gone. It is only through this part that the vasculature continues, which is why threatened abortion, that is bleeding in the first trimester but the pregnancy didn't abort, the pregnancy continued, is a risk factor for small for gestational age because this placenta is somewhere partially separated and that partial separation is going to persist throughout pregnancy and that part which was supplying the fetus is completely gone permanently till that pregnancy lasts, which is why bleeding in the first trimester is a reason why the baby may not grow to its optimal potential. Apart from that, Down syndrome, of course, aneuploidy, PAP A is going to be less than 0.4. We can even consider it to be 0.5. Ultrasound findings may if there is echogenic bowel, because again, echogenic bowel is an indicator of aneuploidies, pregnancy-induced hypertension, preeclampsia, of course, preeclampsia again, maternal weight gain, even low weight gain, unexplained antepartum hemorrhage. Similarly, antepartum hemorrhage, matlab the placenta is getting separated. If the placenta is getting separated, then obviously you are going to have issue with the blood circuit, the blood perfusion that occurs through that separated part. And lastly, exposure to caffeine. Caffeine again is going to increase your sympathetic drive. It is going to keep you awake, and that is going to lead to small for gestational age. And this is how all your risk factors are going to be spoken about. So, to summarize all of these, I have taken this. You can take a screenshot of this picture. This is a summary of all the risk factors under one single column that you can see over here. Everything is here given in front of you. Everything that I spoke in the last 20 minutes is given over here. Take a screenshot. This is just a summary. This is taken from the Foxy का good clinical practice good clinical practice का जो उनका booklet आता है उसके ऊपर ये दिया recommendations में से ये दिया हुआ है. Next. Now, I've spoken about diagnosing. I've spoken about I've spoken about the risk factors and क्यों होता है, कैसे होता है. What do I do about it? So, for me to be able to do something about it, the next question is going to be how to predict कि ऐसा होगा or how to prevent if I couldn't predict on time, and if I even couldn't predict on time, then at least how to diagnose once it has already happened. These are the questions that should make or get me into thinking कि ये कैसे हुआ है और इसको मैं अभी क्या कर सकता हूँ. So हाउ डू यू प्रेडिक्ट? तो प्रेडिक्ट करने के लिए मैं स्क्रीनिंग करूंगा ऑफ रिस्क फैक्टर्स को स्क्रीन करूंगा, रिस्क फैक्टर पता करूंगा. दिस कैन बी डन प्री कंसेप्शनली और एट द फर्स्ट विजिट व्हेनेवर द पेशेंट कम्स टू मी. If the screening ka time is gone, or if the screening has not been able to give me anything fruitful, then I will be monitoring her regularly to suspect if there is impending FGR or small for gestational age. So how do I suspect? And lastly, मैं suspect भी नहीं कर पाया या फिर suspect कर लिया, but I need some confirmation on it, then I will diagnose FGR or SGA. Now, these are the three steps of managing or of looking at FGR. So the first is screening of FGR. So screening, as I've already mentioned, is to be done either pre-conceptionally of all the risk factors that I've spoken ऊपर already वो summary जो मैंने दिखाया है उसको ही बस याद रखना है, और at first visit. So first visit पे elicit proper history करो of previous pregnancy, of all the medical matter comorbidities that the mother has, of her characteristics, a nulliparity, how long has it been since her last pregnancy, all these things, her BMI, everything, all of that to be assessed, either best if done pre-conceptually because you can work on it, you can alter it, you can modify it and give her a better outcome. But if not, very few people come to us pre-conceptually. So if she comes to you directly on a first visit, at least be able to control them now that she's pregnant already. So first visit pe ya fir pre-conceptually, all that summary ka chart that I showed you has to be done for her. Once the screening is done, and now I have to suspect whether there is FGR or not, I always have to have an eye for suspicion. There is a saying that my guide at Sion Hospital, Lokmanya Municipal Medical College, used to say during residency. It was more so being said for ectopic pregnancy that to be able to diagnose ectopic, or to be able to diagnose ectopic without an ultrasound, you have to be ectopic eyed or ectopic minded. Ectopic minded matlab you always need to have at the back of your mind that anything in first trimester might be an ectopic pregnancy. Only then are you going to be able to find. Similarly, you have to always have on your mind that you may have FGR in any random patient even without you knowing कि risk factor exist करता है, and you just have to be FGR or SGA minded for you to be able to diagnose it or suspect it. So how do I suspect it? So to suspect it, I will be doing her physical examination in every visit to me. And by physical examination, which I do in the second and third trimester, I'll be looking at fundal length, fundal height और symphysis of fundal length. तो उसको common करके मैं symphysis of fundal height बोलता हूँ. Symphysis of fundal height, remember that 1 centimeter per week के रेट से बढ़ता है बेबी का लेंथ between 14 to 32 weeks. So 1 centimeter per week बढ़ता है. But if the lag is more than 3 centimeters, then I will start suspecting FGR or small for gestation age. So if the lag is more than 3 centimeters, then I will start suspecting it. But the problem is that this method has very low sensitivity. Sensitivity मतलब इसमें से मेरा मिस होने का चांसेस बहुत ज्यादा है. More so if the patient has things like fibroids, or there are multiple pregnancy, basically twins है, या फिर there is polyhydramnios, and all these, or maybe even oligo, I'll end up underestimating, or malpresentations like transverse lag, I can end up underestimating or overestimating the symphysis fundal height. Hence, a good way, but not a great way, let alone the best way, but it is good enough for you to suspect. But I cannot leave it at merely suspicion. I need to be able to know it for sure if there is FGR or not. And for that, now that you have the resources, you have to do ultrasound for all the patients. So for that, for suspicion plus diagnosis, I have the best gold standard modality, and that happens to be my ultrasound, USG. USG maybe, what all things do I have to see? First of all, I have to check her effective fetal weight or abdominal circumference as per the Delphi criteria that we have already spoken. And Delphi criteria के बाद में early versus late का तुम लोग diagnosis लगाओगे. Secondly, I have to check for her fetal interval growth monitoring or interval growth. What is interval growth? An interval of 4 weeks. ये 4 weeks के बीच में you have to see कि कैसे आ रहा है. You get those charts. ऐसे charts आते हैं. वो charts में you have one 95th centile, you have one for 50th centile, and then you have one for 5th centile. कभी कभार इधर 90 और इधर 10 भी रहता है, anything can do. ये charts तुम लोग को यूज करना. Now there is one thing that you have to know, that all your books, most of your books, and even on the internet, you get charts that are made for Caucasians. If you use those charts for Caucasians, almost all Indian babies are going to fall below 10 centile, because our babies are always going to be smaller than them. Except those exceptions, apne exceptions, 3.6, 3.7 kgs are their average baby weights. Remember that. So their charts are not going to be useful for us. For India, we have to use Indian charts. You have to search them that way, or there are several academies in India. There are several academies. There is Mediscan in Chennai by Dr. S. Suresh, a legend in ultrasound and obstetrics and gynecology. He has made his own charts. The problem is they're a little expensive and they are only taken or bought by ultrasound people and not by OBGYNs. But there are Indian charts and you have to only use Indian charts. इसमें क्या देखना है? मुझे ये देखना है कि एक तो मेरा जो बेबी है, ये सबसे तो पहले ये 10 सेंटाइल जो है उसके नीचे ना आ जाए. उसके नीचे आता है तो मुझे एसजीए का डायग्नोसिस लगाना है. अगर थर्ड के नीचे आता है तो मैं एफजीआर का डायग्नोसिस लगा दूंगा. अलोंग विद दैट, इफ नॉट दिस, इफ देयर इज अ फॉल इन ग्रोथ बाय मोर देन 2 क्वार्टाइल्स. क्वार्टाइल्स मतलब क्या? क्वार्टाइल मतलब 25. 2 into 25 मतलब मोर देन 50 सेंटाइल्स. सो डायरेक्टली मेरा पहला ग्रोथ था 76, बट 4 weeks later it came to be 21. So the fall has been of 55, which is significant, which is more than 50 centile. और पहले it was 91, मस्त एकदम था. It was literally large for gestational age, and then in the next visit 4 weeks later it came out to be 30. Significant drop. 60 का drop almost आया है, 59 का drop आया है, which is again significant. So between that period of 4 weeks, if that drop has been of more than 2 quartiles, 2 मतलब 25 25 2 quartiles, or in other words more than 50 का अगर quartile से centile का difference आता है, then also you will call that fetal growth restriction. Now, this is how you diagnose fetal growth restriction. Apart from that, the last important parameter is Doppler. Doppler में कौन से parameters है? I have already mentioned about uterine artery. I have mentioned about umbilical artery. I have mentioned about ductus venosus. एक बचा है वो है MCA. And here comes my next important concept, that is MCAPI. Now, baby wanted 100% of the blood. 100%, amazing. जब ये finding आया that umbilical artery का PI was increasing, but it was not yet absent. Tabhi, the baby's placenta was less than 90% functional. आगे जाके it became absent end diastolic flow in umbilical artery. तब less than 70% of the placenta was functional. Finally, जब reversal of end diastolic flow आ गया in umbilical artery, the placenta was less than 50% functional. So this is how your placental functionality can be determined by your umbilical artery. Now, as your blood is, or as your placenta is reducing its function or it's getting dysfunctional, your baby says that I have to, whatever little blood that I'm getting now, I have to make sure that my important organs are survived first. What are the important organs for a baby or for a fetus? It says my brain is very important to me. Of course, I need it. My heart is very important to me. My adrenals are very important to me. Why adrenals are going to be secreting your mineralocorticoids and glucocorticoids, which are actually, and your catecholamines, which are actually flight or fight hormones, and your steroid hormones. In fact, your NEET PG ka question used to be, which is the most important hormone, and you used to answer it, aldosterone, mineralocorticoid. So these three important organs that are keeping you alive. What are the non-important organs? Baby says, I can sacrifice them. It includes your kidneys, it includes your liver, it includes your skin, it includes your gut, that is your intestines. These are all your non-important organs. It says I do not want to supply. So all the blood from these non-important organs is shunted to these important organs. Very, very important. So when the blood is shunted to them, we call it brain sparing effect or heart sparing effect or an adrenal sparing effect. उसमें से brain sparing effect is very common. So how does this sparing occur? So ये जो नॉन इंपॉर्टेंट वेसल्स है, उनका अगर पहले वेसल इतना डायमीटर का था, इट नाउ बिकम्स इतना सा. Whereas ये जो ब्रेन का वेसल था, जो पहले इतना था, वो अभी बन गया है इतना. Basically, the diameter has increased. If the diameter has increased, the resistance has gone down. रेजिस्टेंस हैज गॉन डाउन मतलब एमसीए दैट इज मिडिल सेरेब्रल आर्टरी ब्रेन के ऊपर एमसीए नाम का एक वेसल होता है उसका जो रेजिस्टेंस इंडेक्स या फिर पल्सेटिलिटी इंडेक्स है दैट हैज गॉन डाउन. So the dilatation of your middle cerebral artery is reducing the resistance, and that is an indicator of you having brain sparing effect. If I'm going to take a ratio of this MCA PI upon umbilical artery PI, and if it is less than 1, it indicates that brain का इतना dilatation हो गया है कि you umbilical artery से जितना भी blood आ रहा है वो almost पूरा brain को जा रहा है, and less than 1 is diagnostic of brain sparing effect. This is called as the cerebral perfusion ratio, also called as the cerebroplacental perfusion ratio, but this is that ratio which is very important, and brain sparing effect is division ratio इनका less than 1. This is a very important vessel. So MCAPI less than fifth centile. ये जो सेंटाइल्स है वो इंटरनेट पे तुम लोग डालोगे तो तुम लोग को मिल जाएंगे. देयर इज बार्सिलोना कैलकुलेटर गूगल करना है बस, उसमें जेस्टेशनल एज डालने का और पीआई का वैल्यू डालने का, यू गेट द सेंटाइल. सो एमसीएपीआई लेस देन फिफ्थ सेंटाइल और अम्बिलिकल आर्टरी पीआई मोर देन 95th सेंटाइल. सो अम्बिलिकल आर्टरी पीआई का रेजिस्टेंस बढ़ रहा है whereas एमसीएपीआई का रेजिस्टेंस कम हो रहा है. दैट इज हाउ योर ब्रेन स्पेयरिंग इफेक्ट इज गोइंग टू फंक्शन. Did everyone understand this concept? I hope everyone is understanding this concept, a very important concept. Fall of 2 percentile. I will answer all those questions about Doppler normal. Is it FGR? Yes, Nikhil, yes. Drop of 2, but ये अगर गिर रहा है, it is FGR. Correct. Okay. So these are the various Dopplers that are going to be important for me to understand कि क्या क्या इसमें मुझे जरूरी है जानना in Dopplers, and this USG is going to help me diagnose about all these FGR versus SGA वाला dilemma. ठीक है, अब हो गया मेरा डायग्नोसिस ऑफ FGR. इसके बाद में मुझे करना है ये FGR क्यों हुआ है, बिकॉज नाउ आई नीड टू ट्रीट इट. अगर ट्रीट करना है मुझे उसका कॉज एटियोलॉजी पता होना बहुत जरूरी है. सो नाउ आई कम टू डायग्नोसिंग द. अभी डायग्नोसिस मेरा एफजीआर का पक्का हो गया, but now I need to diagnose the etiology so that I can treat it accordingly, because the treatment for a diagnosis of torch infection is going to vary from the diagnosis of uteroplacental insufficiency. So how do I diagnose the etiology? So I have maternal factors that I have to test for, I have fetal factors that I have to test for, and I have placental factors that I have to test for to know the exact etiology. How do I determine that? Now, ये है मैटरनल फैक्टर्स. सो मैटरनल फैक्टर्स में सबसे पहले ऑल सिस्टम्स आई एम गोइंग टू टेस्ट. हिमेटोलॉजिकल में फर्स्ट मैं सीबीसी करूंगा. सीबीसी में मुझे अगर अनीमिया है, पेरिफेरल ब्लड स्मीयर देखूंगा एंड पीटीआईएनआर करूंगा. क्यों? CBC is going to give me a CBC PTNR. This is going to give me an idea of HB and secondly platelets. If the HB is low, it indicates anemia. Anemia in India, the biggest cause is chronic anemia of not chronic anemia, anemia of malnutrition, which is a form of chronic anemia. But the problem is that anemia of iron deficiency is not a concern because the syncytial trophoblasts contain something called as ferroportin, which sucks all the maternal iron to itself and ensures कि mother का एज भी 3 क्यों ना हो, अपना खुद का एज ही 16-17 रहेगा, literally like a parasite. That ferroportin works very heavily during pregnancy because of various reasons that we have discussed in anemia ka session. Now, this ensures that maternal iron deficiency anemia is not leading to fetal iron deficiency anemia, and hence the fetus is growing well despite iron deficiency. But the problem is, iron deficiency is not existing alone. It is coexisting with other micronutrient deficiencies, several micronutrients, magnesium, zinc, biotin, B12, everything. बहुत सारे micronutrients, minerals come here. This is the reason why the fetus may not grow, because those micronutrients, microminerals, all these trace minerals are what are lacking in that mother, which is why this full body count, though it is telling me about anemia, it is also telling me that the mother is nutritionally malnourished, and hence the baby is probably having that FGR or small for gestational age. Similarly, on peripheral blood smear, I'll get to know iron deficiency ka picture hai ki nahi, hypochromic, microcytic, coagulation profile if there is preeclampsia का हेल्प सिंड्रोम. हेल्प सिंड्रोम में या फिर DIC में अगर पेशेंट का ये सीवियर प्री इक्लेम्पशिया के बाद या फिर एंटीपार्टम हेमरेज हो गया है, एंटीपार्टम हेमरेज की वजह से PTINR कोagulation प्रोफाइल इज deranged, very likely. Next, biochemical markers. Biochemical markers में blood sugar to know about diabetes mellitus, liver dysfunction to know about HELLP syndrome and various other disorders, HELLP syndrome or AFLP, all these syndromes. So liver function test, renal function test to know whether there is chronic kidney disease prior to pregnancy, जिसकी वजह से endothelial dysfunction हो रहा है, and finally urine analysis to look for urine protein अगर है या नहीं, again pre-eclampsia. Autoimmune markers, ANA for knowing ANA and dsDNA for knowing about SLE, that is systemic lupus erythematosus. Definitely, again, a chronic autoimmune condition. Body में autoimmunity रहेगा, chronic inflammatory state, endothelial dysfunction. Next, thrombophilia. एंटीकार्डियोलिपिन, लूपस एंटीकोagulants एंड बीटा 2 ग्लाइकोप्रोटीन, ये दोनों का रिमेंबर IgM एंड IgG दोनों इंपॉर्टेंट है. अनलाइक टॉर्च जिसमें सिर्फ IgM इंपॉर्टेंट है, इसमें दोनों इंपॉर्टेंट है. Now there is a syndrome, there is a new concept called as obstetric Aplar syndrome, OAPS. The usual Saparo classification or the Saparo criteria used to say that 12 weeks apart you need to have this laboratory criteria positive once 12 weeks apart, दो बार मतलब. बट द ऑब्स्टेट्रिक एप्ला सिंड्रोम सेज कि 12 वीक्स रुकोगे तो 3 महीना चला जाएगा, उसमें तो पेशेंट माइट अबॉर्ट और माइट हैव ऑलरेडी गॉटन एंटी फॉस्फोलिपिड सिंड्रोम की वजह से FGR. So they say that even if it is coming out to be positive once, you can diagnose it as obstetric Aplar syndrome and you can start that patient on LMWH or unfractionated heparin. So that is obstetric Aplar syndrome. Diagnosis of any one of these antibodies in your body, even once during pregnancy, is enough to call it Aplar syndrome or obstetric Aplar syndrome. I have already mentioned how do they damage your syncytial trophoblasts and all your villus trophoblast. बेसिकली जब तुम लोग प्लासेंटा का एप्ला पेशेंट में अगर प्लासेंटा का हिस्टोपैथोलॉजी करोगे आफ्टर डिलीवरी, यू वुड सी दैट देयर इज फिब्रिन डिपोजिशन अक्रॉस ऑल द विलाय which has in fact damaged all your villus structures. Hence Aplar syndrome, because of villi are also getting damaged and so are your spiral arterioles, your uterine artery PI is also high, whereas your umbilical artery Doppler is also going to be abnormal. Next, maternal serology, toxoplasma, all those torch infections. तो torch PCR मैं करना चाहूंगा to know. Of course, when would I test this? If I'm seeing all those intracranial calcifications, hepatic calcifications, ventriculomegaly, all these things, if I'm seeing, then I'll be checking for maternal serology for torch PCR. And if I see them, I'll also do direct amniocentesis to check the amniotic fluid for this PCR. Next, ultrasound. Ultrasound for screening for knowing uterine artery Doppler, of course, multiple gestation है या नहीं, या फिर are there any problems like fibroid or is there any placental uterine anomaly like septate or bicornuate जहाँ पे baby is not able to have its own placentation very well and hence poor placentation की वजह से the baby is not able to grow. So that is another cause that I'm seeing on ultrasound. For looking at fetal factors, मुझे detailed anatomy basically लेवल 2 स्कैन टिफा स्कैन करना है अच्छा सा, मुझे उसमें सब कुछ दिख जाएगा. नेक्स्ट, जेनेटिक इवैल्यूएशन इफ रिक्वायर्ड, इफ आई थिंक देयर इज चांसेस ऑफ एन्यूप्लॉइडी और सम single gene disorder, then I'll do karyotype, chromosome microarray or whole genome sequencing, basically all the genetic tests. Lastly, infections. If I see that there is any chance of all these factors that I just mentioned, ventriculomegaly, calcifications, cataract, congenital cataract, then I'll go ahead and I'll test for amniocentesis for torch infections. Lastly, for evaluating placental factors, now placenta factor can be only evaluated postpartum because I have to send the placenta for histopathology. If you see it grossly, histopathology, you would see that there are multiple calcifications. You would see yellowish discoloration, basically fibrin and fat depositions, lipid deposition. You would see in a very classical patient who has had FGR. माइक्रोस्कोप के नीचे देखोगे तो ये फाइब्रिन डिपोजिशन देखोगे, सो ऑल दीज फाइब्रिन नेक्रोसिस ये सब देखोगे, बट दैट कैन बी ओनली इवेल्युएटेड पोस्टपार्टम. उसका यूज कब होगा? अगले प्रेगनेंसी में, टू हेल्प हर avoid it, by which ways I'm going to be talking about it next. But these are all the investigations that you'll be doing to determine maternal, fetal and placental factors for fetal growth restriction. Now I have spoken all about diagnosis, suspicion, and how to know the etiology. How do I treat it? So the first management is going to be coming to the management part. Before going to the management part, has everyone understood this? Understanding has been adequate? I have several doubts. I'll be answering all of them at the end. I just hope you all are liking the lecture because I just hope you all are liking it, of course. And if not, just let me know what are the different things that I can be changing. I hope you all have liked it. Please let me know in the chat. Okay, so now how do I manage it? So first thing is going to be management में medical therapy. Medical therapy में we have few unproven या फिर partially proven things versus partially or fully proven things, fully proven drugs. Now, how do I determine which drug and what to give when? So, for all these management related factors, I have several ways in which I can treat it. So, first of all, I do not have to treat wrong dates, of course. I do not have to treat constitutionally small babies. No need. I have to treat non-placental wale and I have to treat, of course, placental wale bhi. Non-placental वाले में अगर एन्यूप्लॉइडी है या फिर कोई लीथल एनोमली है, so the only treatment is to get rid of that fetus to do MTP because it is not going to have any future. Whereas if there is torch infection, I would briefly tell you what can be done. Torch में से जो T है toxoplasma, उसके लिए you can give spiramycin. Unfortunately, spiramycin only reduces the transmission of virus from baby mother to baby. It does not delete or remove the virus that has already reached the fetus and has caused all the stigmata of toxoplasma. Similarly, rubella के लिए absolutely there is rubella के लिए there is no solution. There is no treatment. It can only be prevented by vaccination. And CMV, again, no treatment. They are saying Val acyclovir is a treatment, but it is still under study. And herpes simplex virus, ke liye, you have to give acyclovir. The problem is that if it is affecting you before 12 weeks, then it becomes very difficult because it has affected your period of organogenesis. And remember, once it affects, it takes around 8 weeks for all those changes to come up. So once it has affected, once your report has come to be positive, mother के torch PCR का report positive आता है, IgM positive आता है, उसके 8 to 10 weeks बाद you have to do an anomaly scan or a torch PCR of the amniocentesis का sample to know whether it has caused any changes or defects or not. So the treatment, very few treatment, most of them अगर second third trimester में हो रहा है तो कुछ ज्यादा फर्क पड़ेगा नहीं, but first second trimester में हो गया तो बहुत सारे anomalies आने वाले हैं. Abort करना would be a wise option then. Placental factors, the more important part. So ये जो placental factors है, I'll just write it नीचे ही ऐसे. जो placental factors है, उसके लिए क्या क्या है मेरे पास? सबसे पहले सबसे बेसिक और easiest is going to be bed rest. बेड रेस्ट से क्या होता है, मेरा सिंपैथेटिक ड्राइव कम होता है. माय सिंपैथेटिक ड्राइव रिड्यूसेस. सिंपैथेटिक ड्राइव कम होने से मेरा कैटेकोलामीन्स कम होगा, एड्रेनालिन एपिनेफ्रिन ये सब कम होगा. इसके वजह से मेरा ब्लड प्रेशर कम होगा. ब्लड प्रेशर कम होने से मेरा blood perfusion to the fetus is going to increase and more shearing of the vessels is going to be prevented. Very basic thing, partly beneficial. Next is going to be I have to understand that बेड रेस्ट से एक और चीज होता है, वो है लोअर लिम्ब में जो भी फ्लूइड कलेक्ट होता है बिकॉज ऑफ द ग्रेविड यूट्रस, इट रीलोकेट्स बैक टू द central blood vasculature and the perfusion to the uterus also increases, especially in the left lateral position. Next I have aspirin. Aspirin क्या करता है? It is given in a low dose format. What is low dose? 60 to 150 मिलीग्राम के बीच में कोई भी डोज दो. 81 mg is the ideal dose. Unfortunately 81 इंडिया में नहीं मिलता है, यूएस में मिलता है. Aspirin, when we give it, it does two things in low dose. Thromboxane A2, which is a vasoconstrictor, it reduces it, whereas prostaglandin I2, which is prostacyclin, a vasodilator, it increases that. So vasodilatation increase hota hai, vasoconstriction reduce hota hai. Along with that, it also reduces platelet aggregation. So basically, in my entire body, whenever there are factors that are causing endothelial dysfunction like SLE, chronic kidney disease, chronic hypertension, diabetes mellitus, Apla syndrome, all these conditions, every single condition, wherever you know that there is endothelial dysfunction, you have to start them on aspirin. And this aspirin has to be ideally started when that remodeling is occurring, which is 12 weeks, say. The best effect is if you started between 12 to 16 weeks, the effect is zero after 28 weeks. So this is the best window to start aspirin on. A lot of people started in the first trimester. There are theoretical reports of salicylate toxicity, And salicylate teratogenicity, I have not seen them, but लोग है बोलते हैं तो ठीक है, 12 weeks से start करो, it is still going to be good enough. Next is heparin, very interesting drug. बहुत सारे private practitioners heparin start करते हैं. They, when you ask them क्यों, they say नहीं पता. They say blood को पतला करने के लिए. अरे blood को पतला करना क्या होता है? Why do you want to thin your blood? Why do you want to anticoagulate your blood? You say let us just test for all those thrombophilias, lead-in-5 factor mutation, prothrombin gene mutation, uh, protein CS deficiency, or you can check for APLA syndrome. If all of that is negative, then why are you still giving heparin? What is the reason? I studied that a lot. No one was able to answer me. I read a lot about it and finally I found the answer. Now, APLA syndrome, remember the name is antiphospholipid antibody syndrome. There are several phospholipids on your body. You are only checking for three of them: lupus anticoagulants, beta 2 glycoprotein, and anticardiolipin. But there are still many other antibodies in your bodies which we can test under extended APLA profile. But all those undiagnosed subclinical antigens जिसके against ये APLA के antibodies bind करते हैं, we will never know about them. And they might be the reason why your recurrent pregnancy loss is occurring. And you may not even have a test to diagnose them. सब चीज के टेस्ट नहीं होते अपने पास. Now, to empirically treat this, heparin is given because it is said that it not only anticoagulates your blood, but also, especially in LMWH, has an action where it goes and binds to all your antibodies and nullifies it, negates it, kills it. And all these antiphospholipid antibodies are going to be neutralized by this heparin. So it's an effect that a lot of people don't know about yet. They will know about it. So two effects: anticoagulation to fight against undiagnosed APLA antibodies, and also anticoagulated blood will flow very easily through the small spiral vessels, spiral arterioles, and also because it binds to all those antibodies and nullifies it, negates it, destroys it. That is why heparin empirically works. कभी कभार काम करता है, कभी कभार नहीं करता है, but जब करता है, this is the reason why it works. So both LMWH versus unfractionated, जिसमें से LMWH is what I would prefer. Next, I have um, several other unproven benefits wale like sildenafil, which is a phosphodiesterase 5 inhibitor. Sildenafil hai. फिर statins है, atorvastatin, rosuvastatin. Then I have nitrous oxide donors. बहुत सारे ऐसे drugs है. I have VEGF agonists. I have proton pump inhibitors that are now coming into play for their angiogenic, pro-angiogenic effect. Statins and PPIs, these two are known to have pro-angiogenic action. Basically, the same action that was being destroyed by those SFLT2 and soluble endoglyne, these two drugs are being said to increase that. Even VEGF, it increases your angiogenesis. Apart from that, several other drugs like hydrogen sulfide and melatonin एंड क्रिएटिन, ये जो जिम ब्रोज लेते हैं, एन acetylcysteine and microRNAs, several of these things, everything is under trial. 10-15 years down the line, I believe, in my opinion, statins and sildenafil are going to get much more common in practice. अभी नहीं है but आएंगे काम में. So these are all the medical drugs that you have to be knowing about. And now I come to the last session, last part of my session, and that is management for placental problems and how to deliver them, when to deliver them. So management में monitoring and when to terminate. So first of all, how do I monitor? The simplest way is DFKC, daily fetal kick count. I have to tell her that every time she has food, that is at breakfast, lunch and dinner, for the next 1 to 2 hours, your baby, because of your glucose spike, is going to move a lot. That is your peak period of movement, and within that entire day, 3 meals के बाद का एक घंटा, so 3 hours in the entire day, if the movements are more than 10, you do not need to worry about it. This is also called as cardiac kick count of 10, जिसमें 2 hours के अंदर it has to move for at least 12 hours के अंदर it has to move for at least 10 times. So DFKC या cardiac count of 10 to घर पे बैठे बैठे patient can know whether her baby is doing well or not. Then I have fetal heart rate monitoring. Whenever she is admitted or whenever she comes to my OPD, FHR sunta hu and I send her home. A better form of that is CTG. Nowadays, we even have computerized CTG. So CTG is basically I take a strip of 20 minutes, if required 40 minutes extended CTG, and I know how the baby is doing, what is the baby's well-being. I've discussed it in one of my previous sessions as to how does a CTG work. Remember that whenever there is hypoxia to your brain, to the brain of the fetus, at that point of time, that hypoxia damages your autonomic nervous system. Your autonomic nervous system is responsible for those baseline beat to beat variability, accelerations, and your autonomous nervous system is also completely developed after 32 weeks. So it is pointless to do CTG or BPP, modified BPP, जिसमें NSTB लेते हैं, before 32 weeks. It has to be done only after 32, 34 weeks, because 34 तो पूरी तरह से बन जाता है ANS, 32 के पहले it is underdeveloped. So you may get falsely negative or falsely non-reactive CTGs before 32 weeks. So remember to do CTGs and BPPs only and only after 32 weeks, not before them. Why? Because your autonomic nervous system develops after that. And because of your autonomic nervous system, your wakefulness of the baby improves. And hence, if there is hypoxia, your autonomic nervous system is impaired. And hence, there won't be accelerations, there won't be beat to beat variability, and you would see non-reactive CTGs. Apart from that, Doppler, which we have already studied. Now, Doppler की अगर मैं बात करूंगा तो I have the last two images for the day. How do I know when to terminate? So if the fetal weight is between third and 10th centile, that is only small for gestational age, the risk of stillbirth is low. I have to do a scan every 2 weeks. उसमें से Doppler 1 to 2 weeks कर सकता हूँ and NST once a week करना जरूरी है. After 37 weeks, 1 to 2 times a week तो definitely करना है, but the more important part is growth scan every 2 weeks and Doppler every 1 to 2 weeks as per your convenience. If it is uncomplicated FGR that is less than third centile, but there are no Doppler changes, in that scenario, by the way, Nikhil, this answers your doubt. Less than 2 centile का गिरना भी FGR ही होता है. Then growth scan every 2 weeks and Doppler I would want to do it every weekly. मैं 2 weeks नहीं करूंगा, I would do it every weekly. Again, BPP to be done weekly at least once, if possible twice. If there are mild changes, FGR मतलब less than 3 centile तो है ही ये, but with mild changes like umbilical artery PI is raised, basically umbilical artery resistance is raised. In that scenario, you can advise her admit that patient, and more so if she has other comorbidities like SLE, kidney disease, hypertension, preeclampsia, admit her diabetes. Give her steroids because you never know when can this raised umbilical artery PI can become absent end-diastolic flow. You may have to deliver her prematurely. So give her steroids without fail. NST definitely 2 times a week. Even Doppler to be done 2 times a week. Growth scan can be done every 2 weeks. That's okay, but Doppler has to be done 2 times a week. What are those mild changes? MCA PI less than fifth centile. Remember, it is given or. ये और दिया हुआ है, this or CPR less than fifth centile. और यूट्राइन आर्टरी मोर देन 95 सेंटाइल. सो बेसिकली यूट्राइन या अम्बिलिकल आर्टरी का रेजिस्टेंस बढ़ना या फिर एमसीए का रेजिस्टेंस कम होना. In that scenario, you would have to consider these things: BPP twice a week, Doppler twice a week, and steroids. If there is absent end-diastolic flow or reversal, you have to definitely admit them and you have to terminate them. कब terminate करना है मैं वो भी बताता हूँ. So if the baby is between third and ninth centile, then you have to deliver at most by 39 weeks. Do not go beyond 39 weeks. Normal delivery, induction of labor by PGE2 gel, dinoproston gel can be considered. If it is less than third centile, but the Doppler studies are normal, so FGR hai, but stage 1 FGR hai. In that scenario, you will have, by the way, stage 1 FGR is Doppler के changes के बिना, stage 2 is absent end-diastolic flow, as stage 3 is REDF, stage 4 is reversal in ductus venosus. So if there are no changes, then induction can be done. Don't go beyond 38 weeks if it is less than third centile. In fact, I to recommend कि 37 पे deliver कर दो if it is less than third centile. But if it is less than third centile and there are these early changes like umbilical artery PI is raised or MCA PI is raised, reduced or CPR is less, basically अगर ब्रेन स्पेरिंग इफेक्ट आ चुका है तो 37 के आगे जाओ मत, 37 पे डिलीवर करो. इंडक्शन कर सकते हो. यू कैन कंसिडर सिजेरियन सेक्शन इफ योर सीटीजी इज नॉन रिएक्टिव. Also, oligohydramnios, which is an indicator of chronic hypoxia, at that point of time also you have to deliver by 37. Oligohydramnios, that is AFI below 5 centimeters, should not go beyond 37 weeks. Remember, kidneys are a non-important organ. So kidneys का जब blood supply कम होता है तो urine production भी कम होगा. And hence oligohydramnios is an example of chronic hypoxia. Lastly, if there is absent end-diastolic flow, you terminate it maximally by 34 weeks. I prefer to terminate it immediately once 32 weeks are crossed. REDF, once 30 weeks are crossed, again, I would want to deliver it immediately. The delivery mode has to be cesarean section because labor ka jo contractions hai, when the blood flow is impaired even further, the spiral arterioles are all stopped. They are all blocked. The baby will not receive any blood at all. There will be intrapartum fetal demise. Do not take that risk. Do a cesarean section. And finally, agar ductus venosus, the last possible ominous change, if it is to occur, 26 to 30 weeks के बीच में deliver करो. Cesarean section is the only way. The viability of this fetus is going to be very low. And that is how you would be managing your patient and deciding when to terminate it. After delivery, baby का तो ख्याल रखेंगे neonatologist. For you, you have to advise that female that you had all these risk factors in your current pregnancy. So in your next pregnancy, you have to start yourself on aspirin. You have to do these scans. NT-NV scan करना है, dual marker करना है to know the risk of preeclampsia FGR. Placenta, send for histopathology. If you get some villus changes in it, then do test for APLA because she might have APLA. So postnatally, you have to counsel for all these things. And with that, I finish today's session. I'll be answering all your doubts now. Everyone has asked plenty of doubts. I'll just be answering all of them now. So the first question is, sir, अगर SGA के मतलब है कि इफेक्टिव फीटल कम है बट डॉपलर्स नॉर्मल है? नो, SGA और FGR का मतलब यही है. SGA इज एनीथिंग लेस देन 10 सेंटाइल. डॉपलर्स अगर एबनॉर्मल है तो स्टेज ऑफ FGR बढ़ता है, नथिंग एल्स. If your SGA में, if your fetal weight is less than 10 centile, but there are also Doppler changes in it, then you will again call it FGR. Next, centile, I have explained centiles already. You can just go back and you can see. Explain dual marker. See, dual marker has two purposes. Dual marker का दो purposes ये है. एक है for you to know aneuploidies, beta HCG and PAP-A. Your normal, देखो, योर 11 वीक्स टू 14 के बीच में करना है तुम्हें ड्यूअल मार्कर. 11 वीक्स पे जो बीटा एचसीजी और पैप ए का वैल्यू रहेगा, it is not going to be the same at 14 weeks. It is going to increase. So how can I have a range that is common for this and this? So instead, we have a statistical method called as MOM, multiples of median. This may we see that between 0.5 to 2 अगर बीटा HCG and PAP A है, so it is normal. If it is less than that or more than that, then it is abnormal. So if it is less than that, both of them, if they are less than 0.5, then it is an indication that the placenta is small, which is why the beta HCG is less. So is the placenta associated, pregnancy associated plasma protein is also less. Hence, that is an indicator that the placenta is small. Small placenta मतलब hypoxia. Hypoxia मतलब baby को कुछ तो problem आने वाला है. It is a predictor of preeclampsia and FGR. So dual marker not only predicts aneuploidies, it will also predict your preeclampsia and FGR the risk. Can FGR be associated with polyhydramnios? It can be associated actually. See, late FGR is going to be affected. वहाँ जहाँ पे placental perfusion, placenta is normal. The baby, probably the mother had overt diabetes mellitus, जिसके वजह से वैस्कुलोपैथी की वजह से बेबी का प्लासेंटा खराब था. बट ओवर डायबिटीज की वजह से बेबी कंटिन्यूसली यूरिन इंक्रीज करा था, सो पॉलीहाइड्रामनियोस भी हुआ. एंड अलॉन्ग विद पॉलीहाइड्रामनियोस यू आल्सो हैड FGR. So that is one of the possibilities. In asymmetrical IUGR, do we need to do torch testing every time? Are nahi, not always. It is mostly done for symmetrical IUGR if you have those ultrasound findings that I've already mentioned. So calcifications in brain, calcifications in liver, or ventriculomegaly, all these things, if they are there, then you have to test for it. Could you write the anti-angiogenic factors again? Yes, the anti-angiogenic factors are SFLT2 and soluble endocrine, soluble FMS like tyrosine kinase and soluble endocrine. This sequence happens fall of two centiles, but Doppler's normal. I've already explained that means brain sparing effect. RG से हाँ RG preg sacharol arginine aminophate ये सब जो drugs है they are all nitrous oxide donors. Unproven benefit trials अभी भी चल रहे हैं. ये amino acid वाले जो donors है they increase the vasodilatation by increasing the endothelial nitrous oxide production. ENOS का enzyme E capital NO छोटा S एंडोथेलियल नाइट्रस ऑक्साइड सिंथेटेज इसका प्रोडक्शन बढ़ाते हैं, वो इसको एक्टिवेट करते हैं, विच इंक्रीजेस नाइट्रस ऑक्साइड. नाइट्रस ऑक्साइड डायलेट्स my small vessels and it leads to increased blood flow to the baby. So unproven effect, trial चल रहे, but दे दो, उससे कोई दिक्कत नहीं. But remember it also contains sugar, so monitor your diabetic patient का sugars. Aspirin to be stopped at 36 weeks. Sir, I have read in areas that MCA abnormal with normal umbilical. Which condition fits that? MCA अगर abnormal with normal umbilical artery Doppler है तो do the ultrasound again. you probably may have some wrong ultrasound. But if MCA-PI is low, then you are progressing towards less CPR as well, because the ratio will reduce, and towards brain sparing effect. सर अगर थर्ड ट्राइमेस्टर में यूट्राइन पीआई सिर्फ 95 सेंटाइल है तो उसको एडमिट करके स्टेरॉइड्स दे? नो, डोंट डू दैट। एडमिट मत करो उसको, कंसिडर करो स्टेरॉइड्स माइल्ड चेंजेस से, यू कैन कंसिडर, बट एडमिट करके नट दो, ओपीडी के बेसिस पे दो। इवेंचुअली 37 to 38 के बीच में उसको टर्मिनेट करना है। एंड यूजुअली स्टेरॉइड्स आर गिवन less than 34, no. All the recent guidelines, ACOG, RCOG both recommend कि 37 तक देना है, irrespective of anything. 37 तक steroids देना है, irrespective of whatever your seniors and faculty says. You give it till 37. All the guidelines say that now. So that is it about all the questions. I hope everyone understood. Please, I am reading the live chat. It was a session that I've put in a lot of effort in after a long time. I would want you all to tell me if you liked the session and if you understood everything. I would love knowing it. Please let me know if you like the session in the live chat. The live chat will not be available later on, so please let me know. And I hope I have understood everyone's pyramycin safe in pregnancy. Yes, it is safe, absolutely. IgG अगर torch positive है, nothing to do. Torch IgG positive मतलब the mother is already immune. She is, क्या बोलते हैं उसको? She is good. She is resistant to it. She is immune to it. So yeah, that's it. We are done with the session. Thank you so much then, everyone. This is Dr. Aditya signing off. Please let me know if you all have liked this session. And thank you so much, everyone. And good night. I hope you all liked the session. And if you all have any doubts, do let me know. I'll end this session. Do message me. I'll be answering it live for you then. Thank you so much and good night.